Good evening, friends. So I'll be giving a very brief overview on this topic, Frusemide stress test. So the reason I thought I would talk about this is recently we had a bit of our team had a bit of an altercation with one of the senior cardiologists who possibly wasn't fully cognizant of the evidence behind this Frusemide stress test, and uh, and we had to dawn upon our other interspecialty that there is a reasonably good role for this particular tool that we use in ICU. So for all the listeners, it is important. So obviously, when you're running a closed ICU, we would encounter on such contentious issues, and the only defense during that time is to deliberate on the current evidence that is prevailing and a good evidence-based medicine that we all intensivists follow, because many a times don't assume that everyone is aware of everything. So there is a lot of fluidic changes that happen in the evidence, and it is good to be updated. So this just goes on to show that all my videos that I put in, I request all the intensivists to utilize them to defend the good practices that we do in intensive care. I think that's the message I want to give from this, because this one, which we consider it as something that we use it, and the other specialties were fully agnostic to this. So it is important that we keep constantly getting updated so that we showcase what we are doing is a good ethical and evidence-based medicine that we adopt. So that's the context setting as to why I thought I should do this. And I wish to acknowledge my colleague, Dr. Pratibha, who helped me develop this content, and she was part of that debate that we had with other specialty. So let's just reflect upon the Frusemide. So Frusemide, I'm sure all my good friends in ICU know Frusemide is a diuretic. So it is bound to albumin. So basically, it binds to the albumin. So mechanism of action, just to rewind our knowledge from pharmacology days. So the Frusemide sort of gets transported to the proximal convoluted tubule by human organic acid transporter. So this is the key transporter which delivers Frusemide to the proximal convoluted tubule, where its predominant mechanism of action is. And then it tends to block the reabsorption of sodium, potassium, and chloride in the collecting tubules, and then it promotes secretion of water because there is failure of reabsorption of sodium, potassium. There's more secretion of water in the tubules. So in the whole process, it causes removal of sodium, potassium, calcium, and water from the kidney. So that is the primordial action of the Frusemide. And predominant tool that is needed for Frusemide's effective action is albumin, because it binds to the albumin, and human organic acid transporter. So there are three types of HOAT. HOAT1 transporter and HOAT3 transporters are what are critical for promoting or facilitating the action of Frusemide of the proximal convoluted tubule. So, and it blocks the reabsorption of sodium, potassium, and chloride from the collecting tubules and promotes secretion of waters in the tubules and causes excretion of all these components. So in critically ill patients, so the Frusemide activity can be interrupted by a lot of changes that happen in critically ill. Of course, the albumin level, if someone is very hypoalbuminic, like typically in chronic liver disease, because Frusemide acts by binding to the albumin, so hypoalbuminemia impairs its effectiveness of Frusemide. So you could have some sort of a resistance to potency of the Frusemide action in the setting of hypoalbuminemia, which is not uncommon in critically ill patients. And in critically ill, there is lot of changes that happens. There is redistribution of the sodium potassium ATPase, which sort of impairs the activity of this human organic acid transporters 1 and 3, and that also leads to ineffectiveness or potency of Frusemide action. And the typical type of ICU patients that we see are patients with acidosis or uremia. They competitively sort of acts with along. So there is a competitive sort of an action from the HOAT, because the uremia, metabolic acidosis, cephalosporins also compete with the human organic acid transporters for their action. So in the setting of uremia, metabolic acidosis, and cephalosporins, the potency of Frusemide could be affected because they compete with the human organic acid transporters. And vasopressin levels, they tend to increase the sodium, potassium, and chloride transporters, because these are the transporter systems that are present in the tubules, collecting tubules. So vasopressin tends to increase this, so that may, of course, affect the action of furosemide. And in the acute kidney injury where there is oliguria, there is increased concentration, serum concentrations of furosemide that tends to happen. So these are the sort of changes that tends to happen in the critically ill milieu of a patient, and certain factors that tend to affect the potency of furosemide. I think for intensive, just in the presence of acidosis, in the presence of uremia, and in the presence of antibiotics, which we tend to use very often, and hypoalbuminemia, potency not necessarily can be predictable the way that happens in a normal physiological condition, is what you may have to keep in mind. So now the question is furosemide stress test. What do we understand by furosemide stress test? So this is not a new concept. So this was first described way back in 1973 by Beck et al. In post-surgical patients. So it's not a new concept. So every doctor should at least be aware even before they embark on arguing about utility of such a tool. And the systematization of its usage sort of came later on in 2000s. So it's a dynamic test to test the functional integrity of the renal tubules and the tubular function of the kidney. So that is the primordial intent of doing this furosemide stress test. And this whole standardization and systematization of furosemide stress test basically came at around in 2013 from the US authors by Chawla et al. So where they suggested that glutamate stress test is a robust predictor to determine the progression of acute kidney injury to stage 3 of Akin classification. I'm sure I won't go into the details of Akin 1, 2, 3 sort of stages of the acute kidney injury. It was found to be a good predictor of progression of the kidney function or kidney failure to Akin 3 was what was identified in this. And studies were done based on the observational data, and therefore its ability to predict progression to Akin 3 area under ROC curve was 0.8. So which means it had a good predictive capability to determine the progression of someone who is going into stage 3. So how do we do furosemide stress test? If someone is not exposed to furosemide, which we call as furosemide naive, so the understanding is we give 1 milligram per kg of IV furosemide as a bolus. In someone who has already had a furosemide before, the dosage that is suggested is 1.5 milligram per kg IV is given as a bolus, and we look for what is the urine flow rate in first 2 hours. So this is the key element. So whether we are able to convert oliguric to non-oliguric acute kidney injury, and that response need to be seen in 2 hours. And this 2 hours is based on multiple observational data and the studies, which I will talk about. And if urine flow rate is more than 2 hours in first 2 hours, then it means that furosemide stress test is positive or there are FST responsive. And if the urine flow rate is less than 200 ml, then it means is the furosemide stress test is non-responsive. So this is our understanding. So for all the trainees, remember in ICU, we would possibly assume that most of them may have had exposure to furosemide. If they have had exposure, it is 1.5 milligram per kg we give and observe for 2 hours. If there is a urine output more than 200 ml, then they have been responsive to furosemide stress test. And where does this come from? It comes from large observational data where they found in 2 hours, as you see, the receiver operation characteristic of area under curve was the best when they looked at 2 hours. Because if you look at 3 hours, it tends to come down. So the maximum sort of a number that they could achieve was at the end of 2 hours, which was 0.87. So ROC of 0.87 was the highest they could achieve in 2 hours. And they looked at the sensitivity and specificity of how much urine should come. So as you see, if it was less than 200 ml, so the sensitivity and specificity 200 ml, that ballpark figure we take as more than 200 ml to be positive, had the best sort of sensitivity and specificity to look at sort of making a interpretation of furosemide stress test. So that's why 200 ml at the end of 2 hours was taken from this observational data from the Chawla et al. Study. And so we'll just look into certain studies which have looked at the utility. So this was a study that came from Japan, where they looked at response to different furosemide doses predicts AKI progression in ICU setting with elevated plasma angle. So where they have looked at FST having had a good correlation with the NGAL. NGAL, as you know, is a biomarker to identify patients who are at a risk of AKI. And furosemide stress test perform as good as NGAL in its ability to determine the patients who would have AKI or who would progress into AKI. So if you look at it, so this is the FR is the furosemide response. If you see AUC, it was 0.87 and NGAL was 0.80. And they looked at the second entity where progression to AKI at stage 3 or death within 1 week also. Furosemide response area under curve was 0.88 and plasma NGAL was 0.81, which means to say that they had a good correlation in NGAL, which is a biomarker of predicting acute kidney injury and progression, had a good correlation with the furosemide response in this particular paper that came from Japan. And this is the ROC curves, which showed progression to AKI and progression to stage 3 and death within 3 days was shown in this particular sensitivity analysis. And if you look at this particular data, so what they showed is in someone who is furosemide responsive, the progression to AKI stage 3 happened in 11%. It means if they respond, it means their progression was much lesser in patients who did not respond. See, this is the group which was furosemide response negative, where you give a slug of furosemide, they did not respond. So which means it helps them to stratify and prognosticate the patients who would progress to stage 3 AKI. That is something that they could identify based on furosemide responsiveness. If they were furosemide response negative, more number 86.7% of the patients progressed to stage 3 AKI. And look at the need for RRT. If they were furosemide responsive positive, the need for RRT was significantly less at 5.6% as compared to the group which were FR negative, furosemide response negative. The need for RRT was sitting at 40%. And even the third one, where progression to stage 3 death at 1 week was 11% in furosemide responsive, as opposed to 93 points. So, which means it had an enormous ability to identify the patients who will do well when you give furosemide response and they start making good urine. It means they do well. They may not go to RRT, and even the survival was found to be better in this particular paper that came from Japan. So, which means it has an enormous value in our intensive care to determine the patients who may not go to RRT and who possibly will have a better survival was what is the importance, which I think every doctor should know before embarking on certain debates on this and trying to challenge this. Okay, and this was another trial that came from US and Thailand group called the FST trial, where they looked at early versus standard initiation of renal replacement therapy in furosemide stress test non-responsive acute kidney injury. So here they took 104 patients. Again, so this is another study which literally endorses the previous Japanese study. So if you see the furosemide stress test responders were 44 and furosemide stress test non-responders were 60. And if you look at the need for RRT, even the furosemide stress test responders was 13.6% as opposed to non-responders, which was 78.3%. It means to say it had a very good predictive ability in trying to determine as to who would go and need dialysis and who possibly we can prevent and avoid unnecessary dialysis by testing them. And this is another interesting thing where they looked at inpatients. So then they took all the non-responsive furosemide stress test non-responders and they saw whether there was any difference between early RRT and standard. So they looked at 28-day mortality, there was no difference. Early RRT or standard, there was no difference. And they looked at 7-day fluid balance or RRT dependence at 28 days, there was no difference between early. So this is, they just took a group who were non-responders and they said whether early RRT and late RRT, whether there was any difference, early RRT or standard, there was no difference with mortality, no difference in 7 days fluid balance or RRT dependence at day 28, there was no difference. But what they found is early RRT patients had more of hypophosphatemia and that was statistically significant. So basically you saw one Japanese trial which said if they are furosemide responsive, then their need for RRT is less and their survival also may be better. And even this particular US study, which is FST trial, also clearly shows if they are furosemide stress test positive, then the need for dialysis is significantly less in this patient was what was clearly shown. So now let us look into this particular trial. So that came from Canada, the Frusemide stress test for prediction of worsening acute kidney injury. So there are three trials, one from Japan, one from US, and this is from Canada. This one also clearly shows the similar thing. They showed 92 patients who were Frusemide stress test negative. They saw that 23 patients went on for progression. So these were patients who did not respond to Frusemide stress test, and they found out of this 23 went on to stage 3 progression with lower urinary flow rate. And even here they saw the duration of 2 hours that was determined by Chawla et al. Was substantiated. Even here they looked at 2 hours if urine flow rate was less than 200 ml. Area under ROC was similar to what I suggested as 0.87. So the 2 hours becomes terribly important to determine as to whether FST is responsive or FST is non-responsive. So now we look into heart failure. So this was a study that came in circulation, mainly looking at the Frusemide stress test and its role in the heart failure. So this was a prospective observational study. Here they looked at heart failure patients, where they looked at the composite endpoint of mortality, hospital readmission, and patients needing cardiac transplant at 6 months for the patients with heart failure. So here they looked at all the patients with decompensated heart failure. They took 156 patients, and here they looked at worsening renal functions with Frusemide stress test happened in 38.5% of the patients. And in this, they divided them into two groups. In the group which had worsening renal functions, with 38.5% had worsening renal functions, they divided whether they were low natriuresis or high natriuresis. Low natriuresis means where urine sodium was low, and this was in 19.9%, which means they took a number of less than 109 milliequivalents per liter of the urine, and they looked at high sodium. So why they differentiated it? To see whether there is any difference, I'll show you. So what they found is in patients with heart failure, if they don't respond to Frusemide stress test, and in the group which has worsening of renal function and who do not respond to Frusemide stress test, there was an increased risk of composite endpoint. There was an increased risk of mortality, hospital readmission, and the need for heart transplant at 6 months was there, where they were Frusemide non-responsive, and there was a progression of kidney failure, where there was worsening of renal functions, who were non-responders. They had a worse outcome with composite endpoint of mortality, readmission, and heart transplantation. In this, they did a subgroup analysis, and what they found is in patients who did not natriuresis, who had a low urine sodium, less than 109, so the risk of adverse events was statistically significant as opposed to who did good natriuresis. And so this was statistically significant in patients where there is worsening of renal function. They were Frusemide non-responsive, but they excreted more sodium in the urine, where urine sodium was excreted more. Where they were high natriuresis, they did not have increased risk of adverse events. So the low urine sodium was taken as less than 109, high urine sodium was taken as more than 109. So the conclusion is this is a very important study for cardiology. In cardiac failure, if they become non-responsive, composite endpoint outcome is bad. But in them, if you do urine sodium, if urine sodium is less, they do worse, as opposed to the one where urine sodium is more than. So if natriuresis, they do better. If there is no natriuresis, they do worse. That's the summary that came out of this particular. It's a very good study, came from Spain. So the conclusions that you was in Frusemide stress test in advanced heart failure. So where there is worsening of renal functions, it indicates there is increased risk of mortality, increased risk of readmissions, and heart transplant at 6 months. But in patients, this risk exponentially or it's much higher, statistically significant in patients who have lower natriuresis, whose lower urine sodium is less than 109 milliequivalents per liter. So the take-home message, so I'll have MCQs at the end of it. So I have a group of 6 trainees. So I'll be asking, because there was a debate on this with one of the senior cardiologists. So it's good our ICU team is fully equipped to handle such challenges. So Frusemide stress test is safe, non-invasive, it's easy to perform, low cost, and it tends to determine the severity of tubular injury and it's a good predictive tool for risk stratification and clinical decision making in patients with acute kidney injury, and it has a good value even in heart failure patients. So this is the summary and take home message for all our intensive care. So submission is you can use this tool. There is a good evidence, and you may be challenged by your other specialties. So please show this video. And it is good to adhere to good principles of evidence base when we are dealing with our ICU patients. And we are here to provide sort of a good evidence based care to save our patients. So that should be the message. And science is the only good defense for all of us. So let's look into the MCQs. So I have my colleague who helped me actually develop this content. So the question is, what is the primary purpose of the Frusemide stress test? So to assess cardiac function in heart failure, to differentiate between pre-renal and intrinsic acute kidney injury, to evaluate electrolyte balance in chronic kidney disease, to measure urine osmolality in diabetes. Dr. Pratibha. Okay, she says the right answer. So it's a B, to differentiate between pre-renal and intrinsic acute kidney injury. So the next question goes to Benjamin, because I think Benjamin may not have been focusing. So what is the standard dose of Frusemide used in the Frusemide stress test for adults? 20 mg IV, 1 to 1.5 milligram per kg IV for non-oliguric, 80 mg IV in all cases, 2 mg per kg for all patients. Benjamin. Yes, Benjamin gives the right answer. So for this, you can extrapolate. If it is Frusemide naive, it's 1 mg. If already someone has been exposed to Frusemide, it's 1.5 mg per kg. So what is considered a positive Frusemide stress test indicating preserved tubular function? Urine output more than 200 ml in first hour, urine output more than 100 ml in the first hour, urine output more than or equal to 400 ml in the first 2 hours, urine output more than or equal to 600 ml in the first 2 hours. Dr. Pratibha, who helped me develop this content. Oh, she's got it wrong. I think, yeah, no, she's right. C is the right answer. Urine output more than 400 ml in the first. So this is a little tricky because more than 200 is what I was suggesting. So if it's more than 200, it can be more than 4, it can be 400 or anything. So 400 is the right answer. C is the right answer. So in the setting of acute kidney injury, a poor response to Frusemide stress test suggests what? Dr. Same goal. Pre-renal AKI, intrinsic acute tubular injury, post-renal AKI, chronic kidney disease. Poor response to. So where Frusemide stress test non-responsive. Same goal. What is it?
B.
Okay, Sengol tells the right answer. It's a B, intrinsic AKI. So the last question, which of the following is a major limitation of the Frusemide stress test? It requires invasive procedures. It cannot be used in non-oliguric patients. It does not provide real-time assessment of kidney function. It may be unreliable in patients on chronic diuretic therapy. Dr. Pratibha. A little, you have to put a little mind. Okay, it looks like my team is a little confused here. So the right answer is D. It may be unreliable in patients on chronic diuretic therapy. So thank you, friends. So I request you all to submit your valuable work to Journal of Acute Care. So again, my request is all my videos. I have more than 500 videos. So if any of you are challenged by other teams about certain evidence, all the evidence or most of it would be found in at least 1 or 2 of my videos. So this was something which I thought I should do, where we were challenged by senior cardiologists. So we had to dig into the evidence, showcase what we are doing is adhering to the sound principles of ethical and good evidence-based medicine. So you can visit my website, www.drpradeeprangappa.com, to read to this lecture. Thank you. Thank you, Manitol.